Hello and welcome. My name is Dr. John Powell, and I'm the Continuing Education Specialist with the UNC Cancer Network. You're joining us today for an RN and Allied Health live lecture. It's February 13, 2019. There are a few things I'd like to say before we get started. If you're having any technical issues whatsoever, please call us at 919-445-1000 or email us at unccn@unc.edu. We have people standing by to help out with any technical issues you might be having. We're on the web at unccn.org, and if you go there, you'll find many resources, including lists of our previous and upcoming lectures, the types of free continuing education that we provide, and the information about becoming a site coordinator or program promoter. Our learning portal is also on the web at learn.unc.org, where you can watch any of our past lectures and receive continuing education credits. Today's lecture, should be in the learning portal in about 4 weeks. You can find us on Facebook, Twitter, and LinkedIn. We'll be using Poll Everywhere today, and we hope that each and every one of you will participate. The easiest way, there are several questions we have prepared for you, and you can interact with the presentation and presenter using Poll Everywhere. The easiest way is to connect through Poll Everywhere on a computer, tablet, your cell phone. You can go to pollev.com. That's pollev.com/UNCCN. You'll see the questions as they appear on the screen. You may respond to them, and you'll see on our screen exactly what the percentage results are for all of our participants. You can also use a smartphone or any phone that has texting capabilities. Just type 22333 in the to field. In the message field, type UNCCN. You'll receive a message saying that you've joined. And then you can just select the appropriate response to the answers, A, B, C, or D, and submit those questions as they come up. At the end of our presentation, we will have the opportunity for you to talk or ask questions using Poll Everywhere, and you can either use texting capabilities or go to pollev.com/UNCCN. This is our first question for Poll Everywhere. Which of the following is a form of integrative medicine? Your options are A, chemotherapy, B, radiation therapy, C, nutritional supplements, acupuncture, and massage therapy, and D, CAR-T therapy. In just a moment, you can put in those answers and when the question goes live, and we'll take a look at your answers. Right now, it is my pleasure to introduce to you our guest today, Dr. Jacob Hill. Dr. Hill is a licensed naturopathic physician specializing in integrative oncology. He graduated with a doctorate in naturopathic medicine and master's of integrative medicine research from the National University of Natural Medicine in Portland, Oregon. His research focuses on dietary supplements, oncology, and global health. He conducts international research in Malawi through the UNC Project Malawi, and also contributes to numerous studies here at UNC. And before we get started, is there anything that you think the audience should know about us? About you, rather, sorry.
Well, I will do a brief introduction in one of my first slides. So I'll go through a little bit of my background and how I became familiar with dietary supplements and cancer care.
Okay, great. Mm-hmm. Let's have a look at that poll. Majority of you, 86%, have said C. 13% say CAR-T therapy, D. How are they doing?
Good start so far. So yes, C is the correct answer. Nutritional supplements, acupuncture, massage therapy are all considered integrative medicine. So good start.
Good.
Yes.
Thank you for everyone who participated in that. Hopefully now you have a good idea of how to participate. And I'm going to hand the controls over to Dr. Hill. And here we go.
Sounds good. All right. Well, first, before I get started, I want to thank John, and I want to thank UNC Cancer Network for inviting me to give this presentation today. I also want to thank everyone who's tuning in from wherever you may be located. So the lecture I'm going to give today is called Safety Considerations when Managing Dietary Supplements and Cancer Care. I decided to make the topic about safety for a few reasons, but mainly because I think a lot of the audience listening today are some of the first-line providers who patients can go to and talk about dietary supplements. You may be the providers who are actually documenting supplements in the medical chart. So I wanted to give you some tips on and things to look out for that can help keep your patients safe, or yourself if you use dietary supplements. So let's go ahead and get started. So as far as disclosures, I don't have any conflict of interest or financial relationships to disclose for this lecture. So a little bit of the outline. I'm going to give an introduction to myself and my background, and then I'm going to go over a few just basic definitions, such as what exactly is a dietary supplement and what are we talking about today. And I'm also going to talk a little bit about integrative oncology. That is the kind of the field that is diving into dietary supplement research and how to use them safely in the clinical care. And then I'm going to give you some resources. I'll give you resources both towards the beginning and end of the lecture that might be helpful for you. And then I'm also going to talk very broadly about health systems and health behavior considerations when it comes to using dietary supplements safely in cancer care. And then I'm going to get more specific and give a lot of clinical examples about herb-drug interactions, mechanism interactions, and nutrient-drug interactions. Sometimes people like to lump all these together as like a supplement drug interaction or just call them herb-drug interactions, but I like to tease them apart because I think different things are happening in the body and there's different reasons for the interaction. So I'll go over all those and give some examples as well. And then I'm going to wrap up and just touch on a little bit of radiation and surgical oncology considerations, as well as anticoagulant considerations with dietary supplements. So John went over a little bit of my introduction. I want to touch on a few things. My background starts in my undergrad in nutritional sciences from Penn State University. And then, like John mentioned, I went to the National University of Natural Medicine, which is an accredited university. I did 2 degrees there, the Master's of Science and Research, and then also the Doctor of Naturopathic Medicine. And I didn't build in too much time today to talk a lot about exactly what naturopathic medicine is or what it entails, but maybe sometime at the end, if there's time for questions, we can go over that. But in short, I was trained very rigorously on dietary supplements and how those can interact with pharmaceuticals. And then after I finished my graduate education, I went to near Chicago, Illinois, to Cancer Treatment Centers of America and did a 2-year clinical residency in integrative oncology. And that's where I really learned a lot of the intricate details about how to keep patients safe while using dietary supplements. So it was a very integrative model. We worked right alongside the oncologist there, and we were there to support the oncologists when they did not know, is this natural product okay to use right now, or should we hold it right now? Is it safe? Things like that. So that was our role. After I finished that, I came here to the University of North Carolina, and I started a 3-year T32 postdoctoral research fellowship in complementing integrative medicine. So I'm full-time research here. I focus mostly in oncology, dietary supplements, and then internationally in Malawi, looking at traditional medicine use in the cancer population. I'm also a part-time practicing physician in Vermont. I have a part-time integrative oncology practice at Vermont Wellness Medicine and Integrative Oncology. So I do practice as well currently. So to get started, we're going to go over some definitions of what a dietary supplement is. This comes from the Office of Dietary Supplements at the NIH. And so dietary supplement is a product that is intended to supplement the diet. It contains one or more dietary ingredients such as a vitamin, a mineral, an herbal product or botanical, an amino acid, or other substances, or their components, and is intended to be taken by mouth as a pill, as a capsule, liquid, tablet, and it is identified on the label as being a dietary supplement. I have some pictures of things that might be considered or are considered dietary supplements. The first one on the bottom left you'll see is curcumin, and you may have heard of this before. It's very common in the cancer world. There's a lot of preclinical data on curcumin, and this is absolutely classified as a dietary supplement, is an herbal product. And then things like vitamin C, vitamin B, definitely dietary supplements. I put medicinal marijuana on there because it's kind of a gray area as far as does it fall into the realm of dietary supplements or more of a it's a controlled substance, right? It is federally illegal, but in certain states and certain places it is available recreationally and over the counter. And when it is available over the counter, it's provided as the whole plant form, which is really treated more as an herbal product. So it kind of falls into the realm of a dietary supplement, but also kind of not because of the federal regulations on it. But I know a lot of integrative oncology providers are diving into the research behind medicinal cannabis and what that entails. So integrative oncology, I don't know, maybe some of you have heard of this field, maybe not. But integrative oncology is really focused on being a patient-centered and evidence-informed field in the cancer care that utilizes mind and body practices, natural products, which is what we're talking about today, and or lifestyle modifications from different traditions alongside conventional cancer treatments. So integrative oncology really aims to optimize health, support quality of life, and clinical outcomes across the cancer care continuum, and is to empower people to prevent cancer and to become active participants before, during, and beyond cancer treatment. So I think one of the most important things that comes out of this definition is that integrative oncology works alongside conventional cancer treatment. Integrative oncology is not supporting alternative cancer treatment, which is, it doesn't support telling patients to not do chemotherapy and do these other natural products. It's really there, and I think it shines in supportive cancer care, supporting quality of life, reducing symptoms, and that's what integrative oncology is about. And it does definitely look at a lot of the dietary supplements as well as mind-body lifestyle modifications, things like that. I put a list of what I think is the four kind of basic foundations of integrative oncology. I created this list. This isn't necessarily the list that comes from the Society of Integrative Oncology, which is the national organization. But I think the four top things that are fundamentals to integrative oncology are: one, patient safety, making sure what patients are using is safe and okay for them at that time in their treatment. And that's why I wanted to give this lecture today. But also managing over-the-counter supplements, natural products, exercise, mind-body approaches, as well as supporting quality of life and symptom reduction. I mentioned that I feel integrative oncology really shines there and does well. And then also being as evidence-based as possible. It's really important to rely on what evidence is out there that shows support for safety and efficacy. I'll touch on that a little bit more later in the presentation. So this slide just shows you, all the different integrative medicine centers in the United States. Integrative medicine is alive and well. It's definitely growing. There's a lot of interest in it right now. This isn't necessarily integrative oncology centers, but integrative medicine. And this list comes from the Academic Consortium of Integrative Medicine and Health. Within North Carolina, there's UNC, there's Duke, and then there's Wake Forest. So there's a lot of big-time medical centers that are looking at integrative medicine. Okay, so just a few resources for you to get started. I put the website up for the Society for Integrative Oncology. It's a good resource for you. Here at UNC, if you have access to UNC, we do have some integrative medicine clinical programs such as yoga, massage, and acupuncture, and the link there can help you connect you with those. The ASCO Post has an integrative oncology section. It has some really good information, interesting information there. And then also at UNC, there are mindfulness courses, both for patients and providers. And so you can follow that link, and that's within the program of integrative medicine, where those mindfulness courses are held. And then the gentleman on the left, I put his picture, Dr. Gary Asher. He is a director of integrative medicine services for the Lineberger Comprehensive Cancer Center. And he is available to patients to meet with them and discuss their interest in integrative oncology or supplements or whatever it may be. He's there to help. So that phone number there is to help schedule patients for integrative oncology consults. Okay, so I'm going to get into some broad discussion about health systems and health behavior considerations when it comes to dietary supplements in cancer care. So the National Institutes of Health has an Office of Dietary Supplements, and it's a smaller office, but it does have a lot of good information. One of the things that it does have is called the Dietary Supplements Label Database. And this database has the label information for approximately 76,000 different dietary supplements that are available in the U.S. market. That is a lot of products out there, and they may not all be absolutely different. There may be a few, few curcumin supplements, a few same green tea supplements, but that's a lot of products. And when you combine that information with studies that show that the prevalence of dietary supplement use in cancer care reaches as high as potentially 73%, that means that there's millions of patients that have access to tens of thousands of products that all can have implications on their health and their treatment plans. So that's a lot of people, and that's a important thing to consider, especially when certain providers sometimes find it easier to tell patients, well, we don't know much about dietary supplements. Don't take any. Just don't take any dietary supplements. And I want to caution against that simply because that can sometimes push patients away from maybe seeking out conventional treatment for cancer, and we don't want them to be pushed away from conventional treatment of cancer. So I think having an educated discussion with patients is really the best way to go about their dietary supplements, and then hopefully information that I can share today can help have a good conversation with patients about keeping them safe with their dietary supplements. But when you have so many products available and so many people using them, it kind of brings up the question, who is trained and available to manage all these dietary supplements and over-the-counter products? Now, I put this kind of long list of different providers, and I've personally seen every single one of these providers give recommendations to cancer patients on dietary supplements. And you can see by the different variety of providers on there that they're trained very differently, and so they're likely going to be giving very different recommendations. And this can be very confusing for patients. When you ask the question, who is trained and available to manage these, I think a lot of us would agree that the oncologist should have the final recommendation as far as, is it okay or not okay to do something as far as their cancer treatment. But I know a lot of oncologists don't have the time or the training to learn about all these different over-the-counter or natural products. I think pharmacists are a really good resource when it comes to keeping patients safe as far as herb-drug interactions. They know a lot of the pharmacokinetic and the pharmacodynamics of both natural products and pharmaceuticals, but again, they're not necessarily trained heavily on all these over-the-counter products. So I think this kind of represents a little bit of a void in our health system as far as I don't know if patients really have a good avenue in all our health systems in the United States or a good person to turn to in their care team to talk to them about dietary supplements over-the-counter products. So I mentioned a lack in the number of qualified practitioners, and let's hypothetically say that licensed naturopathic physicians are a good practitioner that people can turn to. However, there are less than 6,000 licensed naturopathic doctors in North America and less than 200 who specialize in supportive cancer care. So that's clearly just not enough. There's also a lack of quality research evidence. Now, when I say this, I want to point out that there actually is a lot of research on dietary supplements. There is a lot of preclinical research, but also it's challenging to have enough research for all those different products to know exactly which dose is safe in which situation. So it makes it hard to have enough research evidence to set things like standards of care, to say, in this clinical situation, we should be using this dietary supplement at this dose. So it makes it a little bit challenging. You have to work with sometimes what research evidence is there, and sometimes have to deal with a little bit of a lack of research evidence for certain products. Lack of insurance coverage for paying for dietary supplements. This sometimes prevents patients from seeking qualified practitioners because those practitioners aren't covered by insurance, or the recommendations or the dietary supplements aren't covered by insurance. And so patients then turn to trying to make decisions on their dietary supplements by themselves, and they don't necessarily have guidance on doing so. And then lack of quality products or availability of products. I'll get to this a little bit more in the next slide, but dietary supplements have limited regulations and standardization of products. They are not regulated the same way that pharmaceuticals are. And also, occasionally, the highest quality products are only available to licensed practitioners. So this makes it inaccessible, some of them inaccessible to patients unless they can afford to go see a licensed practitioner, and that's not always the case. So that means that certain patients don't have access to some of the higher quality products. So when it comes to supplement production and making dietary supplements, it can be very, very complex. Dietary supplement regulation began with the passage of, it's called the Shea Act in 1994, And this did initiate some regulatory measures such as good manufacturing processes, which is good. However, there are a lot of little intricate variables to consider when you're looking at the production and processing of dietary supplements. And it makes this a very complex and a very heterogeneous procedure among suppliers and producers. So I put up a list of questions that all have implications as to the quality of the product that eventually someone is taking. So things as detailed as, what is the soil quality used for growing herbs? And when we think about this, is the soil contaminated with heavy metals? Do those heavy metals make it in the final product? Is the lack of soil quality affecting the active constituents of the herbal products that you're taking? And when I say active constituents, I mean the actual molecules in those herbal products that are having an effect in the body. Are you harvesting at the correct time of year? Do you harvest an herb in the spring? Maybe during the spring it has higher levels of active constituents, or harvesting during the winter. Maybe it's more dormant and it doesn't have as many active constituents. Are you using the correct part of the plant? Are you supposed to be using the root when the capsule you're using has the leaves in it? Are the final products tested for things like pesticides or heavy metals? Fillers and allergens, common allergens for people. Are you testing to make sure that the final product doesn't have things like dairy or gluten, soy, nuts, things like that? Do the producers account for variations in the level of active constituents? I kind of touched on this, but one plant can have a different amount of the active constituent as the other. So when you package that into a final product, are the companies testing to make sure that there's a certain amount of those, or a minimum amount of those active constituents in the final product? What is the therapeutic dose? There's variations in research dosing, so how do you pick a dose to put in a capsule? How do you account for the mechanism of action when could be tens or hundreds of active constituents in one product? So when you take one plant, a whole plant product, and you put it into a capsule, there's many different molecules within that plant that could be having an effect in the body. So are producers looking at these different constituents, and are they standardizing their products to these constituents? How do you account for low bioavailability of certain supplement products? So when I say bioavailability, I'm talking about moving a product or a substance from the intestines over into the bloodstream. And something like curcumin, which is very common for people to take, has low bioavailability. So do producers of curcumin, are they trying to do things, are they looking for mechanisms to increase the bioavailability to maybe have more of a benefit? And then what form of vitamins and minerals are you using? There's a lot of different forms. Are you using the best form for the intended purpose? So these are all questions that can have an influence and impact on the quality of the final product that you or your patients might be taking. So this is an example of a dietary supplement label from a curcumin product. And I point out with the blue arrow, this product shows that it was tested and there's a minimum of 85 to 92% curcuminoids, which are the active constituents of curcumin that are going to have the effect in the body. And so this company did a nice job to make sure that there's a minimum amount of those active constituents. So when you're taking that final product, you're actually getting some of the active molecules. At the bottom, you'll also see, I highlighted that they also test for, allergens like gluten, milk, dairy. There's no coatings, no binders, no sugar. Some of these things people don't want in their dietary supplements, so they make sure that they're not in there. I know myself and a lot of other practitioners in the integrative medicine, integrative oncology field, they vet their companies that they would recommend to patients to make sure that they're being third-party tested, that they really have good quality control. They're tracking their products from where they're sourcing them to how they get in the capsule. So I just recommend that you have a conversation about supplement quality with patients that you work with. Maybe do a little research on the companies that you like. Make sure that they're looking for some of these things that I mentioned. And then you can point patients into the direction of using products that are of higher quality. Okay, moving into health behavior challenges. This is pretty well known in the field, but there are a lot of studies showing from really all over the world that patients are choosing not to disclose their natural products and their dietary supplements to their oncologist or their cancer care team. And there's a few different reasons that have presented in the research as to why this might be. The oncologist or the care team just don't ask about dietary supplements. There's fear that the oncologist or care team might tell the patient to stop, fear of ridicule or embarrassment, and fear that the oncologist will treat patients differently or stop the conventional treatment. And this goes back to what I mentioned already about, the benefit of having a conversation with patients about dietary supplements instead of just ignoring the issue, because it might lead to worse outcomes. So, all right, it looks like we are switching into our first poll question. The question I put up there is, why is a lack of standardization in the production of dietary supplements a potential health system safety concern? Is it because of A, it could lead to the consumption of impurities such as heavy metals, fillers, and allergens? Is it B, it makes it hard to track adverse events? Is it C, it could lead to variations in active constituents and effectiveness? Or D, all of the above?
I will give people just another few seconds to respond. So far it looks like D is the favorite.
That's good. All right, so yes, D is the correct answer there. I mentioned specifically that a lack of standardization could lead to the introduction of impurities into your final product. As far as adverse events, if you have multiple constituents and you're not exactly sure which one's having an effect in the body, that could make it harder to decide, what is actually causing an adverse event to happen. And then also, like I mentioned, variations in active constituents, are different times of harvesting or different soil qualities, things like that. So yes, good job to everybody who answered the poll. That's absolutely great.
Thank you.
Okay, great. So moving into herb-drug mechanism and nutrient-drug interactions, this gets a lot more specific and more clinical with some examples. So herb-drug interactions, I'm going to go over this because it's one of the main topics of safety when it comes to dietary supplements, but I'm going to go over it very generally and broadly. It gets really complex with the details. I think, if you have more questions about it, if you have access to a pharmacist, they are really knowledgeable about herb-drug interactions, so they could help you as well. So what is an herb-drug interaction? It is the combination of two products, an herb and a pharmaceutical, that when taken at the same time or around the same time, it can cause a change in the clearance of either product from the body. So the body mainly uses pathways in the liver. There's other tissues like the kidneys and things to help clear herbal and pharmaceutical products. And the pathways are known as the CYP proteins. There are several different pathways such as CYP1A1, 1B1, 2D6, or the most common CYP3A4. If you've ever heard of someone say you need to be careful with taking grapefruit juice around medications, that is because grapefruit juice can affect CYP3A4. So herbs and drugs, they can speed up these pathways, and when they do, they're known as an inducer of the pathway, or they can slow down the pathways, which then they are known as inhibitors of the pathway. And this can affect how fast a substance is cleared from the body. So therefore, if someone is using a chemotherapy and they combine it with an herbal product that slows down the clearance of the chemotherapy from the body, it inhibits the pathway. What could possibly happen? Well, the chemotherapy could build up in the body and potentially increase the toxicity or side effects, right? So if the chemotherapy is in the body longer than expected, you might have an increase in side effects of that chemo. Let's think about it the other way. If someone is using a chemotherapy and then they combine it with an herb that speeds up the clearance of the chemotherapy from the body, which is known as an inducer of the pathway, what could possibly happen? Well, the chemotherapy could leave the body too quickly and then be less effective at killing cancer cells. It could be out of the body quicker than expected, then quicker than maybe they've seen in research studies, and then you might have a less effective medication. Of course, we wouldn't want that. So for patients who are really insistent on continuing their herbal products with their chemotherapy, it can be challenging to kind of find a happy medium so that everyone is satisfied. If there's an unknown as far as the interaction between an herb and the chemotherapy, obviously the best thing is just to hold it during the whole time of chemotherapy, hold the herbal product, so that there's no chance of interference. But sometimes people are insistent on continuing it. And so some clinical approaches that you can take. You can hold a herb known to have a potential interaction for 48 hours prior to, during, and for 48 hours after receiving chemotherapy. This way the herbal product is out of the body. You can get the chemotherapy on board, let it do its effect, and then maybe start the herbal product back up again. This sometimes is a good happy medium for patients. However, it obviously would only work for infusions and not for daily chemotherapy. And then you can use the rule of 5 half-lives. So you can multiply the terminal half-life of a drug and an herb by 5, which then tells you that around 97% of each medicine is then eliminated from the body. So we're going to go through an example. And I'll explain towards the end my resources for where I find half-lives and where I find the pathways through the liver that these products are using. I use databases to look at this. So I'll give you that reference and those resources at the end. Well, let's look at an example of combining doxorubicin with green tea. So doxorubicin terminal elimination half-life is 20 to 48 hours. If you multiply this by 5, you get a range between 100 hours and 240 hours, or 4.2 days to 10 days. So it may take up to 10 days for 97% of the doxorubicin to be out of someone's body. Now, if you look at EGCG, which is the active constituent of green tea, the terminal elimination half-life is about 3.4 hours. You multiply that by 5 and you get 17 hours. So let's look at a clinical example. A patient with breast cancer is prescribed doxorubicin infusion every 21 days, and they would also like to take their green tea extract. There is a known herb-drug interaction between green tea and doxorubicin via the CYP3A4 pathway. So when can she technically safely take her green tea extract? Well, let's put the doxorubicin 21-day cycle, write it out, and we know from the previous slide that it could take potentially up to 10 days for 97% of the vast majority of the doxorubicin to be eliminated from the body. Therefore, we could potentially get the green tea on board during the second half of the cycle, and that way there's less risk for an interaction because most of the doxorubicin is out. Now, you would have to stop the green tea extract, 17 to 24 hours before the next dose of doxorubicin, and that would be a safe, happy medium. However, that was a very simplified version of managing herb-drug interactions. This is a little bit more of a realistic picture, and even this is still simplified. Most patients are going to be on 1 or 2 chemotherapies, maybe 3. They're going to have other medications on board, and a lot of times they might be interested in more than one herbal product or a combination product that has multiple herbs in it. So then you're looking at herb-drug interactions between a lot of different things, and balancing that can be very challenging sometimes. So this is a little bit more of a realistic situation, but like I said, even this is a little bit simplified as well. Okay, then I'm going to move into talking about nutrient-drug interactions. So a nutrient-drug interaction is between a vitamin, a mineral, or a food substance such as fat, and a pharmaceutical. The interaction doesn't always involve the liver, but more commonly involves an interaction that can increase or decrease the absorption of a pharmaceutical. So here are some examples that I pulled from the literature. Things like taking abiraterone with a high-fat meal, it can increase the level of the drug tenfold throughout the body. So that's a big difference. And also, when taking procarbazine, it is best to avoid tyramine-rich foods like wine, yogurt, bananas, and aged cheeses because it may precipitate a hypertensive crisis. Again, not a good thing. And then also consuming calcium and or magnesium within 2 hours of taking mercaptopurine can reduce the drug absorption. And calcium and magnesium may have that effect on multiple medications. So these are just examples of nutrient-drug interactions. I'm going to go through a more specific one, and that is folate with capecitabine, or Xeloda administration. So the 2 studies I put up there, they found that serum folate levels and red blood cell folate levels are both significant predictors of toxicity related to capecitabine administration. So that means that they found that individuals with higher levels of internal folate levels in their serum and in their red blood cells, they had worse toxicity when they took capecitabine. So let's think about where we get our folate from and how much we're taking. So the RDA for folate in adults is 400 micrograms daily, so the recommended dietary allowance. Now, mean dietary intakes of folate, including folate from the food we eat or fortified foods, as in folic acid that's added to food, ranges between 454 and 652 micrograms per day in U.S. adults. So typically just eating our standard diets, we're getting enough folic acid. We're getting 100% of our daily folate or folic acid. However, there are other sources that we can get folate or folic acid from, and that's a multivitamin. So if you look there where I have the blue arrow, I know it's a little small, but that's showing you that folic acid is, there's 400 micrograms in this multivitamin, and that's another 100% of our daily value. So it kind of brings up the question, should we be holding multivitamin supplementation during capecitabine administration? Because we know that higher internal levels are predictors of toxicity of capecitabine. So we don't have a study that says that, yes, giving a multivitamin with folic acid is definitely going to lead to a harmful outcome. But again, it's kind of a gray area, and it theoretically might make sense. So to play it on the safe side, it might be best to hold multivitamins in that situation. And then I want to touch base on mechanism interactions. Natural products and pharmaceuticals can have the same or opposite physiological mechanism, as in how they're actually functioning in the body. And this can cause a potential interaction. And the interaction could theoretically decrease the effectiveness of the pharmaceutical or potentially increase the side effects. And two examples that I list are combining immunotherapy with natural immune stimulants, and also stem cell transplants with natural immune stimulants. So I'm going to go into the first example a little bit more. So let's look at the combination of nivolumab and high-dose melatonin. So nivolumab is an immunotherapy. It's a human immunoglobulin. Monoclonal antibody inhibits programmed cell death 1 activity by blocking the things that bind to the PD-1 receptor, which is PD-L1, PD-L2. This upregulates T cell cytotoxicity. So in short, nivolumab, it really takes the brakes off the immune system and ramps up our immune system so that our immune system is helping to fight the cancer. However, a potential adverse reaction is an autoimmune disorder, and a potentially fatal autoimmune disorder. Now let's look at high-dose melatonin. For those who aren't aware, the higher doses of melatonin, up to 20 milligrams, have some preclinical data showing that they might be immune stimulating. So melatonin may increase T helper 17 cell differentiation. It may increase antigen presentation to T cells and production of cytokines interleukin 10, interleukin 1, and TNF-alpha. And all this results in T cell proliferation. So while it's not doing the exact same thing as nivolumab, it's kind of along the same lines. It's kind of pushing the immune system a little bit, through T cells. So then you're going to have to ask the question, would taking melatonin and nivolumab together potentially increase the risk of an autoimmune side effect, right? If you're pushing the immune system with nivolumab and you push it again even harder by adding melatonin, could that increase the risk of your immune system now turning against your healthy cells and inducing an autoimmune disorder? Or you could ask the question, would taking melatonin and nivolumab together increase T cell cytotoxicity towards tumor cells and maybe have more a beneficial effect? We don't know yet. There's just a lack of evidence. You'll hear me say that a couple times throughout the lecture today, in that really the safety issue is in the lack of evidence. In this situation, typically I don't recommend anybody who's on an immunotherapy to do a natural immune stimulant like melatonin. And then I want to touch on the topic of natural immune stimulants and hematological malignancies. So I mentioned high-dose melatonin can be considered like a natural immune stimulant. Also things like medicinal mushrooms and certain herbal products like astragalus are known to stimulate the immune system and can increase T cell cytotoxicity. But it is unknown if stimulating the immune system has a negative impact on someone with a hematological malignancy. So someone with a hematological malignancy, their cancer is within their immune system. It's either within a certain type of cell or cell line or immune tissues. And so we don't know if you take a natural product and you kind of boost the immune system, you're trying to push the immune system, would it only increase good cells or would it also potentially increase bad cancerous cells? So again, we're not sure within the research. So until more data is available, caution should probably be taken regarding the supplementation of natural immune stimulants with hematological malignancies. Another topic that I wanted to cover is estrogenic herbs and hormone-dependent cancers. This topic is a little bit less known among providers, but the growth of certain cancers, such as breast and ovarian cancer, it may be stimulated by exposure to either endogenous or exogenous forms of estrogen. And we know this, that's why we do hormone treatment with ER-positive breast cancer. The receptors on the outside of those cells, when stimulated by estrogen, may induce a growth signal. So we don't want to add any added estrogen exposure for someone with a estrogen-regulated cancer, such as potentially a breast cancer or an ovarian cancer. However, there are certain herbal products that have what we call phytoestrogenic effects. So they have the ability to have estrogen-like molecules that can bind to the estrogen receptors on cells. And so this list is not exhaustive, but all these things on this list do have at least some preclinical data for being able to bind to and stimulate the estrogen receptor. It's not as straightforward as just saying we shouldn't be giving any of these to individuals with an estrogen-regulated cancer. For instance, flax seeds has actually a lot of beneficial data showing that it may be beneficial for ER-positive breast cancer patients and outcomes and helping them. So it's another gray area in the research and the literature. Typically, if someone presents to me with ER-positive breast cancer, ovarian cancer, even endometrial or cervical, I tend to shy away from recommending them taking any of these things. And a lot of these things they might be interested in, things like resveratrol, ginseng, or these things are ginkgo. These things are very common for people to use. Another more specific example is boron and sex hormones and the effect of boron on internal sex hormones. So boron supplementation, there's actually a lot of studies that show this, that it can markedly elevate the serum concentrations of 17-beta-estradiol, so a form of estrogen. And some of you might be thinking, well, who supplements with boron, or what is boron even for? But actually a lot of people supplement with boron because it's in multivitamins. Again, I apologize, that's a little small, that picture, but that arrow is showing you that there is boron added to a lot of multivitamins. So based off of what we just kind of talked about, if you give someone with a hormone-dependent or hormone-regulated cancer a multivitamin with boron, is that going to increase their internal levels of estrogen? And could that potentially lead to a growth-stimulating effect of their cancer cells? We don't know for sure. So again, maybe multivitamins in this patient population might not be the best idea. Okay, then I want to touch on directly harmful practices that kind of fall into the dietary supplement or natural product category. Unfortunately, there are a lot of products out there that really don't have any safety evidence and actually have evidence of harm. And one example is apricot seeds. These can also go by the name of amygdalin or laetrile, and I don't know if any of you have had patients come to you on apricot seeds. I've definitely had patients come to me and say that they're taking them. And it's a common alternative cancer treatment. It was studied a few decades ago for a potential anti-cancer effect. The theory is that amygdalin, which comes from the apricot seeds, is metabolized only by cancer cells, and then it releases cyanide to kill the cancer cells. However, with more research that was done, it was shown that the amygdalin, it doesn't specifically target cancer cells, but was metabolized by all cells in the body and then could potentially lead to cyanide poisoning. So if you do see patients coming in on apricot seeds, they're available online. You can buy them, and they are marketed for cancer treatment. I wouldn't recommend them to continue those. And it's a little bit different, right? If you think about how chemotherapy works, chemotherapy targets rapidly dividing cells. It's made to do that so that it can target cancer and not necessarily just any general cell. But this is different. They don't see it targeting just cancer cells. It's more so that it targets all cells in the body.
I'm sorry. Go ahead.
Okay. Some additional questionable products or practices that you might hear about include things like the internal consumption of high levels of hydrogen peroxide, ozone, kratom is fairly common, and then also insulin-potentiated chemotherapy, or a lot of experimental procedures. And this is for sure not an exhaustive list. You'll hear of a lot of different things out there that people are trying. And you can't necessarily blame them with a diagnosis of cancer. There's a lot of fear, and there's a sense that they want to do anything possible. But just guiding them along their path to trying to find what they want to do can be helpful to keep them safe. Okay, so we are going to go into our second poll question. So this question is about herb-drug interactions. It asks, golden seal inhibits cytochrome P450-3A4, and paclitaxel is a major substrate of cytochrome P450-3A4. So what is a potential outcome of taking these medicines at the same time? So I'll give you a few minutes to answer that.
All right. And we have decreased side effects of paclitaxel as A, increased side effects of golden seal as B, and increased side effects of paclitaxel for C. So far the responses seem to be going for C. So how are they doing?
They're doing great. Yeah, so the correct answer is increased side effects of paclitaxel, and that seems like you guys definitely got the idea that golden seal inhibiting the pathway could mean that the paclitaxel is now in the body longer than expected, which could lead to an increased side effects of that chemotherapy. So something we would want to avoid. So good job.
Thank you.
Great. Okay, so the last little bit here, I'm just going to touch on radiation, surgical, and anticoagulation considerations. So radiation oncology considerations, it's pretty well known that the thing to look out for as far as dietary supplements and radiation are high-dose antioxidants, right? We don't want to negate the benefit of the radiation. Radiation has a benefit because it can go into cells, it can cause free radicals, it can cause oxidation, and that kills the cancer cells. So that's how it can have a benefit. So supplementing high-dose antioxidants isn't necessarily the best idea. Theoretically, it might negate the benefit of the radiation. So there's a lot of antioxidants out there. I didn't put an exhaustive list, but I wanted to mention some that are common in dietary supplements and maybe are a little bit less known and also have some research to show that they may negate the benefit of radiation. So the first two I wanted to mention is N-acetylcysteine and alpha-lipoic acid. There's in vitro studies that found a delayed radioprotective effect after 24 hours in cells that were exposed to 2 gray of radiation due to NIC and other thiol-containing drugs. So there was a negated benefit of the radiation. Also, NAC can block the benefit of radiosensitizing effects in vitro. So those studies show a potential harm in reducing the benefit of radiation. Also, coenzyme Q10. I put greater than 300 micrograms daily. That's a little bit arbitrary. We're not sure exactly which dose is okay and which one is not. But CoQ10 is very common. It's definitely kind of like a buzzword in the supplement world right now, but mouse models do indicate that CoQ10 can cause a lower specific growth delay in mice receiving single-dose tumor irradiation plus CoQ10. So the antioxidant ability of CoQ10 may be limiting the benefit of the radiation. And then last, I just want to mention vitamin A and renal radiation. So rat models have found all-trans retinoic acid exacerbated radiation nephropathy, and with potential mechanism of action being the inhibition of renal nitric oxide activity by the vitamin A. So giving vitamin A to a patient who is undergoing renal radiation may not be the best idea. So those are just a few examples. Some surgical oncology considerations. It is really important to consider the herb drug considerations with anesthesia. You definitely don't want to be messing with the effect of anesthesia. So I also wanted to mention that there are several herbal products that do have the potential to affect blood coagulation. There's a list here. I also have a more comprehensive list on the next slide. But obviously you don't want to be affecting blood coagulation or have a blood thinning effect around the time of surgery. So I have some general recommendations. This is just my personal recommendations that I typically like to follow, and that's to discontinue all herbal products and products with known anticoagulant effect or herb drug interactions at least 1 week before surgery, just to make sure that they're out of the body, they're not going to interfere, and to discontinue all other dietary supplements a minimum 24 hours before surgery, if not sooner. And this is really just a reiteration of what I mentioned on the last slide. So individuals on anticoagulant medication, you might want to be cautious if they are taking one of these products. These have been shown to have an effect on blood coagulation. There's not strong evidence to say that the combination of these products with an anticoag medication does lead to harmful outcomes, But in theory, they might, and again, there's just a lack of information, lack of data on all of these combining with anticoagulant medications, so just be cautious there. Okay, the last little piece of information I wanted to put up is additional resources as far as, the database that I use to find the metabolism of herbal products, such as the pathway that they're using, is Natural Medicine's comprehensive database. If you have access to UNC, then there's access to the Health Science Library to this database. Really helpful. It has a great summary of effectiveness and research resources there for all herbal products. And there's also good information at the National Center for Complementary and Integrative Health, and then also the NIH Office of Dietary Supplements. So we're going to go into our last poll question. The question is, a potential adverse effect of ipilimumab is an autoimmune reaction. Melatonin and ipilimumab share a similar mechanism of action by stimulating the immune system. So what is the theoretical outcome due to this similar mechanism? Is it potentially A, an increased risk for an autoimmune disease, B, decreased risk for an autoimmune disease, or C, decreased effectiveness of melatonin? So I'll just give you a few more seconds to answer that. It looks like we're getting a strong trend.
Very fast.
Yeah, it seems like everyone definitely got that. Ipilimumab is immunotherapy, combining with melatonin, like I mentioned with the example with nivolumab, could potentially, in theory, lead to an increased risk for an autoimmune disease by pushing the immune system even harder. So good job, everybody.
Thank you.
Okay, that wraps things up. It looks like we have about maybe 10 minutes for questions. So I hope that information was helpful and interesting to you. And please feel free to reach out after this with any questions that you might have as well. Thank you.
All right. So I'll take this over here. Dr. Hill also provides some references.
Yeah.
At the end of his presentation, we have a handout available on the website that you can download to get those if you want them. Or you can email me and ask for them. Here's the question slide. So we're waiting for you to send in your questions. And while you are typing in your questions, I have one or two that I'd like to ask.
Sure.
First of all, you mentioned earlier you weren't going to go into naturopathic medicine, but you might do that now. So
Sure.
While we're waiting, maybe you could talk to people about what naturopathic medicine is.
Yeah, good question. There's a lot of misunderstanding as far as naturopathic medicine, and it has to do with variations in licensure per state. So there are, I believe, about 8 schools that are accredited for naturopathic medicine. That means that there's an accrediting body that looks at the education provided, and it requires education on all the basic sciences, just like any other medical school, as well as requirements for the amount of clinical hours you must complete. Most accredited naturopathic medical schools, it's a minimum of a 4-year program. If not, a lot of people do it in 5 years. And most of the schools are located in Oregon, Washington. There's one in California, Arizona, Illinois, and I believe there's one that's starting to open in Maryland. So naturopathic medicine is based on the idea that the body kind of has the innate ability to heal itself, right? And that's kind of the foundation. And using the least invasive things first to try to support one's health, and then, if necessary, going to more invasive things like pharmaceuticals and surgery if needed. But we're trained in a lot of different types of modalities, things like herbal medicines, vitamins and minerals. We're even trained in pharmaceuticals. In certain states, our licenses allow us to prescribe pharmaceuticals. Minor surgery, IV therapy, physical medicine, and chiropractic adjustments, things like that. And then the trouble is that there are also states that are completely unlicensed for naturopathic medicine, which means that they don't recognize the practice and they don't have any regulation over who uses the term naturopath. So there are schools out there who will offer a doctorate of naturopathic medicine degree, but they will give it to you they'll grant that degree after like a 6-month online course. And you're just not going to be able to learn the basic sciences and the amount of education you need to really make good clinical decisions. So, there are people in unlicensed states, and unfortunately North Carolina is an unlicensed state for naturopaths, that people will use that title who haven't gone to an accredited school and they can't hold a license. So if someone is interested in seeing a naturopathic provider, I'd recommend going to the American Association of Naturopathic physician's website, and also making sure that the provider you're using is able to hold a license. They went to one of the accredited schools, and they hold a license in a state that allows you to hold a license. I hold my license in Vermont.
Sounds like good advice. All right, we have some questions. I've heard a lot about essential oils being used aromatically, topically, and internally. What do you know about these?
Yeah, great question. Essential oils super popular right now, and the research is starting to show that internal consumption of essential oils may not be a good idea. There's data showing that it might increase liver enzymes and be kind of hepatotoxic, especially higher doses of internal consumption of essential oils. So I would never recommend someone taking internally essential oils, but use in small amounts topically or for aromatherapy. They can be helpful in certain situations. So that's a good question. A lot of people like to take them internally, but I don't recommend it because we don't have the safety data to say that it's okay. Yeah.
All right, you mentioned medical marijuana. Are there any uses on oncology for CBD, which is from the hemp plant?
Yeah, so CBD is again, something that's very popular right now. And CBD and it can be derived from the hemp plant, and you can get it a lot easier than obviously medicinal marijuana in certain states. I think the data is still a little premature on exactly what CBD can do and where it has an effect. I think a lot of the data coming out is positive, but I think we're not there yet. There's a lot of red tape and a lot of challenges to doing research on products that come from medicinal marijuana, even though I know CBD can come from hemp. But I'm not yet comfortable to say, oh, we need to be using CBD for this. I think right now we know there's a low safety concern. I think it's tolerated very well by a lot of patients. And I know a lot of patients who do choose to use it. You also have to consider interactions with medications, especially if they're using a whole plant product, like a whole hemp product, or the medicinal marijuana product that does have herb-drug interactions with certain chemotherapies. So as far as your question, are there any uses in oncology? I think there are. I think we're still learning about them, though.
All right. When visiting Turkey or Cappadocia a few years ago, I noticed that the local women cracked and ate apricot seeds. Has anybody studied what cyanide level?
Yeah, it's along the same lines as what I mentioned. It's something I wouldn't recommend. It was in the research a few decades ago that they looked at it for a potential anti-cancer effect, but there has been case studies of people having cyanide like toxicity and adverse effects from that, and not necessarily those levels just targeting the cancer. So it's not something that I would recommend, but obviously, yeah, it is out there. But I think there's better alternatives to use than apricot seeds for support, especially, I mean, they're using that as a alternative cancer treatment. I wouldn't necessarily recommend an alternative cancer treatment. I recommend, the conventional, the model, which has the data to show that is the most beneficial and most powerful for fighting and killing cancer cells.
All right, I think I've missed the last part of that. What the study, the cyanide level effects might be in that population. So are there been any studies on the women in Turkey?
Not that I know specifically.
Okay.
Yeah.
All right. I've heard that antioxidants will interact with chemo. What are your thoughts about this?
Yeah, it's an unknown. It's a gray area. I think certain providers have certain levels of comfort with using antioxidants. Some of the antioxidants I mentioned, like ALA and N-acetylcysteine, are kind of considered the stronger antioxidants, so you may want to avoid those during chemotherapy, but something like a low dose of vitamin C, we're getting vitamin C in our foods as well, but maybe 1,000 milligrams of vitamin C. We're not exactly sure, but most providers have more comfort with using things that are more familiar and maybe not as strong of an antioxidant potential as something like NAC or alpha lipoic acid. Yeah. Okay. So it's kind of per provider. I communicate all the time with the oncologists that are managing the patients I work with to see, hey, are you okay with this or that? This is the data that I know, but maybe there's a little gray area. How do you feel about it? So just working with the providers helps.
That's good. All right, we just have a couple of minutes here before 1 o'clock. For our audience, a few things I want to say in wrapping up. I want to thank the North Carolina General Assembly for their generous support of the UNC Lineberger Carpenter Cancer Center and the University Cancer Research Fund. I want to thank the fine folks on our team who make all of these lectures possible, Tim Poe, Mary King, Benderanda Obure. You can find a list of our upcoming lectures at unccn.org/events. Here are the two that are coming up during February and early March. Then we have several self-paced online courses that we've added to our learning portal at learn.unccn.org. There are several that just went in this last month. So please go check these out and all the others on our site. Earn continuing education credits. They're there for you. Thank you all so much for participating. And Dr. Hill, thank you very much for coming in today. It's a pleasure.
Yeah, thanks for having me. Thank you, everybody.
See you next time.